Welcome to the Demonstrating Implementation Excellence stream of SNOMED CT Expo 2024. Thank you to FAST for sponsoring this stream. My name is Sonja Ulrich and I'm the Software Development Manager at SNOMED International. I will be moderating today's session. All questions will be answered at the conclusion of the presentation. Online attendees, please use the Q&A button to type your questions to the presenter. On-site attendees, please use the microphone provided in the room. I'm now pleased to introduce Niklas Eklöf and Erika Kulp from the Swedish National Department of Health and Welfare, who will be presenting Transforming National Statistics using SNOMED CT. Niklas and Erika, please go ahead.
And now? Okay. Good morning, good day, and good evening, everyone. We're super excited to be here. We have a bit of a sore throat, both of us, because we did karaoke last night. So I hope that you can hear us. We're here presenting, or actually giving you a quick overview of some of the initiatives going on in Sweden, where we are trying to transform our national statistic using SNOMED CT. A very quick overview of where Erika and I actually are working. So in Sweden, we have a Ministry for Health and Social Affairs. In Sweden, we have very small ministries. Not a lot of people are working there. Instead, we have bigger agencies. So we're working at the national agency called the National Board of Health and Welfare. And one of our mission is to host the Swedish NRC, which Erika is responsible for. She's Mrs. NRC in Sweden. And we also wanted to show this, and I think that every Swede who has had a presentation this week has shown this picture. And why it's so important to talk about that we are a decentralized country? Well, it's because of the fact that we don't have any national healthcare in Sweden. We have given the regions, we have 21 regions, the mission to provide healthcare for their citizens. So from a national level, you really have to work in collaboration to be able to implement national solutions, such as SNOMED. At the national level, where we're working a lot with legislation, but we're also working with supporting and monitoring and supervising the healthcare system. And me and Erika's agency is responsible for doing this in the healthcare and welfare sector. Then we have 21 regions who are local self-government. They are independent from the national level. They have their own taxation rights and so on, and they are mainly responsible for delivering the healthcare in Sweden. And to add to that, we have 290 municipalities also responsible for some of the healthcare, mainly for the elderly. So in a country with a population of approximately 10 million persons, we have kind of a complex and also decentralized system. But as we said, one of our main assignment is to monitor the healthcare system. And how do we do that? Well, we do that through health data. I think that Sweden has been one of the most prominent countries regarding the health data question for years. We have health data registries. We're going to look at them in a few minutes, which basically covers all of the healthcare and social services in Sweden. They are based on a personal identification number, so we can actually follow an individual through these registries basically from birth until you're not here with us anymore. And we are using this for a lot of things. We are using it to research on public health issues, to see what's happened when we introduce new drugs and pharmacies and so on, and also to follow the overall health in the population. We actually wrote access for all there. That's true in one way, because you have to maintain a certain standard to be able to collect data from the registries, but they are open. So if you're a researcher or an institution, then you can access these health registries and get the data. It's also heavily regulated, and we have a legislation that says that every healthcare provider has to report health data to us as a national agency. So it's mandatory. So we actually have some data from every point of contact with the healthcare in Sweden. And we're also able to cross-reference that data so we can share data between the registries and see other stuff. We've been doing this for a really long time. This is our national registries and when they were developed. So we started in the 50s actually with the cancer registry, and then we just continued. This may look like a success, but it's also a very tricky path because we basically made separate registries for separate diagnostics, which made it quite hard to make use of the health data in the actual healthcare, because you're entering data not specifically for cancer because the patient has the same personal ID even if you're not treated for cancer, or you're entering the person's vital signs not specifically for the birth registry, just because you are in the healthcare system. So we basically created some kind of overhead with these registries where the healthcare providers have to enter data both in their EHR systems, but also entry data for us. But it's been a long way. And as you can imagine, we are also very careful about this data and we want to protect it because we have data on every patient since the 1950s. And these registries are mainly based on ICD. Now we're using ICD-10. We have translated ICD-11 actually and thinking about how to implement it. And also a Nordic Swedish classification for health intervention for procedures called KVO. And what about now, Erica? I'm just going to walk around.
Yeah, go ahead. I'm going to hop in here and we'll talk about modernization of this data and where we're headed. So as you can see, we have three types of scenarios here, and we have a new ecosystem going on in Sweden where new health information systems are coming into play and soon going live. So we need to take a new look at how we're collecting data, and we need to look from the point of our users when it comes to SNOMED CT. In scenario 1 or A here, we're looking at some systems that will use SNOMED CT as the main documentation for example, procedures for their health data. And we hope that also in the soon future, that scenario B will also be relevant as more new systems come in to Sweden and begin to document using SNOMED CT. And then we have our hope, our dream scenario, here C, where all systems in Sweden are able to make use in some way, in some part of SNOMED CT. And that's where we are headed to. But right now, we're in scenario A. So what happens when you have the hope that we have come against 75 years of historical data, and we are wanting to kind of mix that up with SNOMED CT? It's going to be a hard push there. However, when systems become modernized and when users begin to state their needs and their wants to document with SNOMED CT, we as a national agency need to try to meet those needs. And so that's when we're moving over to the mappings. Yes, a necessary evil. We all know how difficult and complex mappings can be. However, in order to utilize SNOMED CT for our users, it's important that we meet their needs and meet them where they are. And that means we are going to have to map. So this brings new conditions here for us that have informed change. And the first one was a call to action from our users, stating that they are keen on documenting with SNOMED CT And it's very important for them to be able to do their clinical documentation with SNOMED CT. And that means that we need to be able to find a way to collect that data, because they would not like to have a high administrative burden. So that's the main point of the mapping there. Then we have our national collaboration. We have a national steering group for information structure with the regions. And then we have our National Board of Health and Welfare. There that Niklas is sitting on that meeting to discuss how we can collaborate. And this is where that call to action came through. It came up through leadership, and it made it real for us to be able to act. And that collaboration was really key to being able to meet that need, to being able to take the call to action seriously and put it into action. And then we have our third area here, where we have a new department, which means that both the health classification and SNOMED CT are now within the same housing. We're together. It makes it easier for us to work together and really look into the mapping, which we're responsible for. We are responsible for the health classification, and we're also responsible for producing and distributing SNOMED CT. So it makes for a perfect storm in all of the areas here. And I say a storm because it's a mapping. But it makes this change happen in more realistic and more available to us now than it ever has. Because the one thing that's really important with mapping is you need a use case. You need to have it where it will be utilized. And without that, it's really hard to do a mapping, and you need all hands on deck for that as well. So just to talk more about that system level approach with our new department, we're looking at how to make things move a bit faster, but also looking into the future. So we have our ACT, study, do, plan. We're really trying to get closer to our regions. We're trying to get closer to implementation. We're trying to understand more what we need to do as a national department to support that implementation, to support the usage of SNOMED CT. And we have this Operation Cat drop. I'm sure you guys have all heard. It's really important to look at unintended consequences. That means starting from the beginning, you're looking at what is this map and what is a use case. But you also need to look at the usability. You also need to look at the long-term maintenance and see where are the connections there? Where are some of the barriers that we have to overcome? And you kind of need to have that at the beginning stages, because when you're doing a map, you need to be flexible and you need to be able to pivot as well. So that's very important. And that's then we come to where we want to be. So with the maturity level of SNOMED CT, of course, you saw our A, B, C scenarios. We're all about the C scenario, where you have all hands on deck and everybody being able to utilize SNOMED CT. And we're hoping to use this mapping as a starting point to make it easier for our regions to be able to utilize SNOMED CT for their needs and to diminish that administrative burden. Then we want to continue our collaborative partnerships that we have with the regions. That is so important to really getting things started, to putting things into action. And then we want to engage interest. We want to get our users beyond those that are informaticians, beyond those that are SNOMED CT nerds, into action and just really encourage them to be involved. We need SMEs. We need education to go out at a higher level for our users. And that's where we really want to be. And then we'll end it here with Han Kang. When a person undergoes such a drastic transformation, there's simply nothing anyone else can do but sit back and let them get on with it. And that's exactly how we're feeling about this mapping. It is time. We are going to sit back. This is definitely a transformation, and we are definitely going to get on with it. And there's nothing anyone else can do about it. At this point, we're going to make moves, and we're hoping that we'll be able to help our regions and support the usage of SNOMED CT at the same time. So thank you so much.
Thank you very much. Great presentation. Niklas and Erika will now take questions. As a reminder, if you're in the room, please use the microphone to ask your question. Yes, Dion has a question.
Thanks. Sorry, is that working? Is it working? Yep. Okay. So thanks for the presentation. Thanks for the karaoke last night as well. So my question is really about the scope and the intended use of the mapping, which could be many things. Do you see that being used so that to allow those regional systems to be able to record in SNOMED and then report to the registries in your existing classification? Or do you see the possibility of ultimately maybe even getting SNOMED data through to the registries and then being able to derive the statistical information they need either to their classification using the map, or maybe even do smarter things than they could before because they've got more granular data?
Should I start?
Yeah.
Oh, but thank you so much. I think that's a really good question. It's basically the question. And I think that given the maturity level that we are at now, this is the first step, doing the mapping, seeing what will happen to the data quality now as a first step. I'm sure that we, in a few years, will look into this mapping and see what if we don't use it anymore and send SNOMED code straightly to the registries. But I think that's the second step. I think that you have to start somewhere, and this is the first step on lessen the administrative burden. What do you say, Erika?
Yeah. And I'll be actually having a lightning talk, and we'll go in a little bit into that, but it'll be really quick, and you can't ask me questions. So I'll try to give a little insight here. Another part of the thing with being able to report in SNOMED CT is our legislation. It clearly states that with our Swedish health interventions that we are to regions are to report in using that. So at the national board, that's what we accept in are those codes. And that would be a big thing, that is a big barrier in how we need to address the regions being able to make it much easier for them to be able to use SNOMED CT and report in SNOMED CT. But right now we're kind of at a standstill based on legislation. Yeah.
One other follow-up, if I may, sorry. Do you anticipate any, I guess, content gaps in SNOMED as well? And do you have any particular plans around that?
Okay. That I also will talk very shortly about, which is really good because that's exactly the point of the lightning session. But we're kind of currently picking out certain areas that have been reported in most frequently. So we're going to start with those in reported areas that we know systems are sending in those health in the health classifications. And that would be like psychiatry, it's internal medicine, surgery, ophthalmology, and breast cancer. So those areas, those 5 areas, we're going to focus on first and see, okay, where can we get the equivalency? We anticipate there will be gaps. And with this new push with SNOMED International and their request to see where we can focus in certain content areas, we're hoping to use that also to be able to use momentum when we do identify those gaps, that we can go in with SNOMED International to really put a priority there so we can get those filled. Yeah, go ahead.
I'm just going to add to that. And yeah, I also sang karaoke. During this week, and I'm sorry, I'm from the Swedish NRC. So during this week, there has been discussions with the SNOMED International team where they're very curious to hear what our output is with regards to this project, because they're also doing, they're looking at procedures as one focus area, and they would very much like our input with regards to the different issues that we might find during our initial pilot, because we're doing this in stages. So just to say that they're following us closely, and hopefully we can contribute to making SNOMED Core better as well.
Yeah, I think that's a really important part of, like, even when someone's doing a mapping project that might be to a very specific and even old coding system that may not be of interest to anyone else. The effort of doing that creates other artifacts for other people. So yeah, I wish you very well. Thanks.
Thank you. Thank you.
Any other questions? There are no questions online. I have a question or two. So you mentioned how important it is to form these collaborative partnerships and to get people on board. And I assume other countries face similar challenges. Do you have any tips or tricks that you could share? Some secrets?
Do you want to talk about the collaboration? I can start, but I think, I think it's common goals, right? So it's very important to see that both of the collaborative partners have a common goal, because that's what energizes each partner, because you do want to get something out of it, right? So that's one of the things. And then also, I think being open to discuss, having a continual dialogue. I think you guys meet how often? Do you want to talk about how often you meet with?
Yeah, sure.
Yeah.
Yeah, and I think that you also have to formalize it in some way, because this is, of course, it's a collaboration, but to be able to collaborate in the best way, you also have to have common grounds, common goals, and a common understanding of what to do. So we actually established this kind of principles for how to collaborate together. And Erica and Anna was actually talking about that yesterday, because that was a big thing for us, not only like catching up and calling each other and asking each other stuff, more to actually have formal meetings once a month. We have the same agenda. We have principles for how to get resources from each other. And I think that made it very clear that in a decentralized system, we need work on every level. So I would say that you have to really take a grasp of it and formalize some bits of it, but also like mix it with other things, because we also established in Sweden open forums for SNOMED CT, where once a month you can meet us at the NRC and basically ask anything, and people actually ask anything or everything or so. And I think that has been one of the things, to be able to meet us once a month, and we can follow their progress, and they can also follow our progress, and they can also ask things that aren't that prepared. They can ask what's on top of their mind, and I think that has opened up the SNOMED questions a lot in Sweden.
Definitely agree.
Thank you very much. Any other questions here in the room? No, was that? Then thanks to both of you. We'll conclude the session. And online delegates, you can stay here for the next presentation in the stream or access another session through the event lobby. Thank you.